Hello and welcome to the Coding Corner, Medical Coding Education. Today we will be covering chapters 9, 10, 11, and 12 of the ICD-10 CM chapter-specific guidelines. My name is Kristen Robinson. I am a coder, auditor, and educator, and let's get into it. Chapter 9, Diseases of the Circulatory System. This is for codes I00 through I99. In this section, we will be covering hypertension, atherosclerotic coronary artery disease and angina, intraoperative and post-procedural cerebrovascular accident, sequelae of cerebrovascular disease, and acute myocardial infarction or AMI. So let's get started with hypertension. Now, this particular section has a lot of guidelines that we need to make sure that we are following. So let's get started. Hypertension has a classification that presumes a causal relationship between hypertension and heart involvement and between hypertension and kidney involvement, as the two conditions are linked by the term with. This is in the alphabetic index. These conditions should be coded as related even in the absence of provider documentation explicitly linking them, unless the documentation clearly states the conditions are unrelated. For hypertension and conditions not specifically linked by relational terms, such as with, associated with, or due to, in the classification, the provider documentation must link the conditions in order to code them as related. So number 1, hypertension with heart disease. Hypertension with heart conditions classified to category I50, heart failure, I51.4 for myocarditis unspecified, I51.89 for other ill-defined heart diseases, and I51.9 for heart disease unspecified is assigned to a code from category I11 for hypertensive heart disease. You'll want to make sure that you use an additional code or codes from category I50 for heart failure or I51 for complications and ill-defined descriptions of heart disease to identify the heart condition. Hypertension with heart conditions classifiable to I51.5 for myocardial degeneration or I51.7 for cardiomegaly is assigned to a code from category I11 for hypertensive heart disease. No additional code is assigned to identify the specific heart condition. The same heart conditions from categories I50, I51.4 through 51.7, I51.89, and I51.9 with hypertension are coded separately if the provider has documented that they are unrelated to the hypertension. The applicable hypertension code I10, essential or primary hypertension, or code from category I15 for secondary hypertension should be assigned. The sequence is according to the circumstances of the admission or the encounter. Number 2, hypertensive chronic kidney disease. Assign codes from category I12 for hypertensive chronic kidney disease when both hypertension and a condition classifiable to category N18 for chronic kidney disease or CKD are present. CKD should not be coded as hypertensive if the provider indicates that the CKD is not related to the hypertension. The appropriate code from category N18 should be used as a secondary code with a code from category I12 to identify the stage of the chronic kidney disease. If you would like additional information on this, you can see section 1C14 for chronic kidney disease. If a patient has hypertensive chronic kidney disease and acute renal failure, the acute renal failure should also be coded, and the sequence is according to the circumstances of the encounter or admission. Number 3, hypertensive heart and chronic kidney disease. The codes in category I13, hypertensive heart and chronic kidney disease, are combination codes that include hypertension, heart disease, and chronic kidney disease. Assign codes from combination category I13 for hypertensive heart and chronic kidney disease. If heart failure is present, assign an additional code from category I50 to identify the type of heart failure. The appropriate code from category N18 for chronic kidney disease should be used as a secondary code with a code from category I13 to identify the stage of chronic kidney disease. Again, if you need additional information on this, you can see section 1C14 for chronic kidney disease. The includes notes at I13 specify that the conditions included in I11 and I12 are included together in I13. That means that you would not code the I11 and the I12 or when you are using I13. Heart disease and chronic kidney disease, then code from I13 should be used, not codes from I11 or I12, as previously stated. For patients with both acute renal failure and chronic kidney disease, the acute renal failure should also be coded, and again, as stated previously, we want to sequence these according to the circumstances of the admission or encounter. Number 4, hypertensive cerebrovascular disease. For hypertensive cerebrovascular disease, first assign the appropriate code from categories I60 through I69, followed by the appropriate hypertension code. Number 5, hypertensive retinopathy. Subcategory H35.0 for background retinopathy and retinal vascular changes should be used along with a code from categories I10 through I15 in the hypertensive disease section to include the systemic hypertension. The sequencing is based on the reason for the encounter. Number 6, hypertension secondary. Secondary hypertension is due to an underlying condition. 2 codes are required, one to identify the underlying etiology and one from category I15 to identify the hypertension. Sequencing of codes is determined by the reason for the admission or encounter. Number 7, hypertension transient. You'll want to assign a code from R03.0 for elevated blood pressure reading without diagnosis of hypertension unless the patient has an established diagnosis of hypertension. Assign code O13 for gestational or pregnancy-induced hypertension without significant proteinuria, or O14 for preeclampsia for transient hypertension of pregnancy. And again, I want to make sure that we all know that Chapter 15 always takes precedence for a patient that is currently pregnant. Number 8, hypertension controlled. This diagnostic statement usually refers to an existing state of hypertension under control by therapy. Assign the appropriate code from categories I10 through I15 for hypertensive diseases. Again, there is not a specific diagnosis code for controlled. Hypertension I10 is all that's needed if it's just stated as controlled hypertension. Number 9, hypertension uncontrolled. Again, There is not a specific code for uncontrolled hypertension. You would code it to categories I-10 through I-15 for hypertensive diseases. Number 10, hypertensive crisis. Assign a code from category I-16 for hypertensive crisis for documented hypertensive emergency, or unspecified hypertensive crisis. Code also any identified hypertensive disease from categories I-10 through I-15. And remember, the sequencing is based on the reason for the encounter. Number 11, pulmonary hypertension. Pulmonary hypertension is classified to category I-27 for other pulmonary heart diseases. For secondary pulmonary hypertension from subcategories I-27-1 and I-27-2, code also any associated conditions or adverse effects of drugs or toxins. The sequencing is based on the reason for the encounter, except for adverse effects of drugs. If you want additional information on this, you can see section 1C19.E. Number 12, and the final section for hypertension, is for hypertension resistant. Resistant hypertension refers to blood pressure of a patient with hypertension that remains above goal in spite of the use of antihypertensive medications. Assign code I1A.0 for resistant hypertension as an additional code when apparent treatment-resistant hypertension, treatment-resistant hypertension, or true resistant hypertension is documented by the provider. A code for the specific type of existing hypertension is sequenced first if known. Next up, we have atherosclerotic coronary artery disease and angina. ICD-10-CM has combination codes for atherosclerotic heart disease with angina pectoris. The subcategories for these codes are I-2511, atherosclerotic heart disease of a native coronary artery with angina pectoris, and I-25-7 for atherosclerosis of coronary artery bypass graft or grafts, and coronary artery of a transplanted heart with angina pectoris. When using one of these combination codes, it is not necessary to use an additional code for angina pectoris. That means you will use the combination code and you would not code from code section I-20. A causal relationship can be assumed in a patient with both atherosclerosis and angina pectoris, unless the documentation indicates that the angina is due to something other than atherosclerosis, which, in my opinion, is very rare. If a patient with coronary artery disease is admitted due to an acute myocardial infarction or an AMI, the AMI should be sequenced before the coronary artery disease. See section 1C9 for more information on acute myocardial infarctions. Next up, we have intraoperative and post-procedural cerebrovascular accident. The medical record documentation should clearly specify the cause and effect relationship between the medical intervention and the cerebrovascular accident in order to assign a code for the intraoperative or post-procedural cerebrovascular accident. Proper code assignment depends on whether it was from an infarction or a hemorrhage, and whether it occurred intraoperatively or postoperatively. If it was a cerebral hemorrhage, code assignment depends on the type of procedure performed. So now we're going to discuss sequelae of cerebrovascular disease. Number 1, Category I-69 for sequelae of cerebrovascular disease. Category I-69 is used to indicate conditions classifiable to categories I-60 through I-67 as the causes of a sequela neurological deficit, themselves classified elsewhere. These late effects include neurological deficits that persist after the initial onset of conditions classifiable to categories I-60 through I-67. The neurologic deficits caused by cerebrovascular disease may be present from the onset or may arise at any time after the onset of the condition classifiable to categories I-60 through I-67. And as a reminder, I would like to also point out that this I-69 code literally can occur immediately with and or after the original cerebrovascular accident. This is not like post 6 weeks or post 4 weeks. Post 4 weeks is with an acute myocardial infarction. So just remember, this can be immediately or after the initial cerebrovascular accident. Codes from category I-69 for sequelae of cerebrovascular disease that specify hemiplegia, hemiparesis, or monoplegia identify whether the dominant or non-dominant side is affected. Should the affected side be documented but not specified as dominant or non-dominant, and the classification system does not indicate a default, code selection is as followed. If you remember from our last session, we discussed dominant versus non-dominant. So I'm going to repeat that for this section. Ambidextrous patients, the default should be non-dominant. If the left side is affected, the default is non-dominant. If the right side is affected, the default is dominant. Codes from category I-69 with codes from I-60 through I-67. Codes from category I-69 may be assigned on a health record with codes from I-60 through I-67 if the patient has a current cerebrovascular disease and deficits from an old cerebrovascular disease. Number 3, codes from category I-69 and personal history of transient ischemic attack, or a TIA, and cerebral infarction. So that would be Z8673 for that personal history of the TIA and or cerebral infarction. Remember, you would never code Z8673 when there is deficits from that cerebral infarction and or TIA. You would code the deficits, not the history of, because history of means that there are no deficits. It is a personal history that is no longer currently affecting the patient. If you want additional information on this, see 1C 21.4 for history of for use of personal history codes. Next up, we have acute myocardial infarction, or AMI. Number 1, type 1 ST elevation myocardial infarction, or STEMI, and non-ST elevation myocardial infarction, or NSTEMI. The codes for type 1 acute myocardial infarction identify the site, such as anterolateral wall or true posterior wall. Subcategories I-21.0 through I-21.2 and code I-21.3 are used for a type 1 ST elevation myocardial infarction, or STEMI. Code I-21.4 is for a non-ST elevation myocardial infarction, or an NSTEMI. This is used for a type 1 NSTEMI and non-transmural MIs. If a type 1 NSTEMI evolves into a STEMI, you'll assign the STEMI code. If a type 1 STEMI converts to an NSTEMI due to thrombolytic therapy, it is still coded as a STEMI. So the point to make here is that no matter if the NSTEMI converts to a STEMI or a STEMI converts to an NSTEMI, the STEMI code will always outweigh the NSTEMI code. For encounters occurring while the myocardial infarction is equal to or less than 4 weeks, including transfers to another acute setting for post-acute setting, or a post-acute setting, excuse me. And the myocardial infarction meets the definition for other diagnoses. You'll want to see section 3 for reporting additional diagnoses. Codes from category I-21 may continue to be reported. This is for encounters after the 4-week time frame and the patient is still receiving care related to the myocardial infarction. The appropriate aftercare code should be assigned rather than a code from category I-21. Remember, this is after the 4-week time period has ended. So during that 4-week time period, it is still a current myocardial infarction. After the 4-week time period, it is aftercare for the STEMI or NSTEMI. For an old or healed myocardial infarction that does not require further care, I-25.2 for an old myocardial infarction may be assigned. Number 2, for a acute myocardial infarction unspecified. For code I-21.9, this is for acute myocardial infarction unspecified. This is default for unspecified acute myocardial infarction or unspecified type. If only type 1 STEMI or transmural MI without a site is documented, you'll want to use code I-21.3 for the STEMI. Number 3, an AMI documented as non-transmural or subendocardial, but the site is provided. If an AMI is documented as non-transmural or subendocardial, but the site is provided, you're still going to code this as a subendocardial AMI. If you want additional information on this, you can see section 1C 21.3 for additional information on coding status post-administration of TPA in a different facility within the last 24 hours. There is also a Z code when a patient is transferred to a new facility and received TPA in a previous facility within the last 24 hours. So make sure that if that's the case for the patient you're coding, that you use the Z code for the administration of the TPA from a different facility in the last 24 hours. Number 4, a subsequent acute myocardial infarction. A code from category I-22 for a subsequent ST elevation or STEMI and non-ST elevation or NSTEMI myocardial infarction. This is to be used when a patient who has suffered a type 1 or unspecified AMI has a new AMI within that 4-week time frame from the initial AMI. A code from category I-22 must be used in conjunction with the code from category I-21. The sequencing of the I-22 versus the I-21 depends on the circumstances of the encounter. Do not assign code I-22 for subsequent myocardial infarctions other than type 1 or unspecified. For subsequent type 2 AMI, assign only the code I-21.A1. For the subsequent type 4 or type 5 AMI, you'll want to assign code I21.A9. If a subsequent myocardial infarction of one type occurs within that 4-week period of the initial MI of a different type, you'll want to assign the appropriate codes from category I21 to identify each type. Do not assign a code from I22. Codes from category I22 should only be assigned if both the initial and subsequent myocardial infarction is a type 1 or unspecified. Now, other types of myocardial infarctions. The ICD-10-CM provides codes for different types of myocardial infarction. Type 1 myocardial infarctions are assigned to I21.0 through I21.4. Type 2 myocardial infarctions, or myocardial infarction due to demand ischemia or secondary due to ischemic imbalance, is assigned to code I21.A1 for myocardial infarction type 2 with the underlying cause coded first, if applicable. Do not assign code I24.89 for other forms of acute ischemic heart disease for the demand ischemia. If a type 2 AMI is described as NSTEMI or STEMI, assign only a code from I21.A1. Codes from I2101 through I21.4 should only be assigned for type 1 AMIs. For acute myocardial infarctions type 3, 4A, 4B, 4C, and 5 are assigned code I21.A9 for other myocardial infarction type. The code also and code first notes should be followed related to the complications and for coding post-procedural myocardial infarctions during or following cardiac surgery. The last one on this screen is going to be your myocardial infarction with coronary microvascular dysfunction. Coronary microvascular dysfunction, or CMD, is a condition that impacts the microvasculature by restricting the microvascular flow and increasing microvascular resistance. Code I21B, myocardial infarction with coronary microvascular dysfunction, is assigned for myocardial infarction with coronary microvascular disease, myocardial infarction with coronary microvascular dysfunction, and myocardial infarction with non-obstructive coronary arteries, also known as MINOCA, with microvascular disease. Next up is Chapter 10, Diseases of the Respiratory System, codes J00 through J99 and U07.0. First up, we have chronic obstructive pulmonary disease, or COPD, and asthma. Number 1, acute exacerbation of chronic obstructive bronchitis and asthma. The codes in categories J44 and J45 distinguish between uncomplicated cases and those in acute exacerbation. An acute exacerbation is a worsening or decompensation of a chronic condition. An acute exacerbation is not equivalent to an infection superimposed on a chronic condition, though an exacerbation may be triggered by an infection. Now, for acute respiratory failure as a principal diagnosis, a code from subcategory J96.0 for acute respiratory failure or subcategory J96.2 for acute and chronic respiratory failure may be assigned as the principal diagnosis when the condition is established after the study to be chiefly responsible for occasioning the admission to the hospital, and the selection is supported by the alphabetic index and tabular list. However, chapter-specific coding guidelines such as obstetrics, poisoning, HIV, and newborn that provide sequencing direction take precedence. Number 2, acute respiratory failure as a secondary diagnosis. Respiratory failure may be listed as a secondary diagnosis if it occurs after admission, or if it is present on admission but does not meet the definition of principal diagnosis. Number 3, sequencing of acute respiratory failure and other acute conditions. When a patient is admitted with respiratory failure and another acute condition, for example, myocardial infarction, cerebrovascular accident, or aspiration pneumonia, the principal diagnosis will not be the same in every situation. This applies whether the other acute condition is respiratory or non-respiratory condition. Selection of the principal diagnosis will be dependent on the circumstances of the admission. If both the respiratory failure and other acute condition are equally responsible for occasioning the admission to the hospital, and there are no chapter-specific sequencing rules, the guideline regarding 2 or more diagnoses that equally meet the definition for principal diagnosis, see Section 2C, may be applied in these situations. If the documentation is not clear as to whether acute respiratory failure and another condition are equally responsible for occasioning the admission, query the provider for clarification. Next, we have an influenza due to certain identified influenza viruses. Code only confirmed cases of influenza due to certain identified influenza viruses from category J09 and due to other identified influenza virus from category J10. This is an exception to the hospital inpatient guideline section 2H for uncertain diagnosis. In this context, confirmation does not require documentation of positive laboratory testing specific for avian or novel influenza A or other identified influenza virus. However, coding should be based on the provider's diagnostic statement that the patient has avian influenza or other novel influenza A for category J09 or another particular identified strain of influenza such as H1N1 or H3N2, but not identified as novel or variant for category J10. If the provider records suspected or possible or probable avian flu or novel influenza or other identified influenza, then the appropriate influenza code from category J11 for influenza due to unidentified influenza virus should be assigned. A code from category J09 for influenza due to certain identified influenza viruses should not be assigned, nor should a code from category J10 for influenza due to other identified influenza virus. For ventilator-associated pneumonia, we have 2 different guidelines. Number 1, documentation of ventilator-associated pneumonia. As with all procedural or post-procedural complications, code assignment is based on the provider's documentation of the relationship between the condition and the procedure. Code J95-851 for ventilator-associated pneumonia should be assigned only when the provider has documented ventilator-associated pneumonia or VAP. An additional code to identify the organism, for example, Pseudomonas aeruginosa, I might be saying that incorrectly, for code B96.5, should also be assigned. Do not assign an additional code from categories J12 through J18 to identify the type of pneumonia. Code J95-851 should not be assigned for cases where the patient has pneumonia and is on mechanical ventilator, and the provider has not specifically stated that the pneumonia is ventilator-associated pneumonia. If the documentation is unclear as to whether the patient has a pneumonia that is a complication attributable to mechanical ventilator, then you need to query your provider. The second guideline for this, ventilator-associated pneumonia that develops after admission. A patient may be admitted with one type of pneumonia, for example, J13 for pneumonia due to Streptococcus pneumonia, and subsequently develops VAP. In this instance, the principal diagnosis would be the appropriate code from categories J12 through J18 for the pneumonia diagnosed at the time of the admission. Code J95-851 for VAP would be assigned as an additional diagnosis when the provider has also documented the presence of VAP. Lastly, for this slide, vaping-related disorders. For patients presenting with conditions related to vaping, assign code U07.0 for vaping-related disorder as the principal diagnosis. For lung injury due to vaping, assign only code U07. Assign additional codes for other manifestations such as acute respiratory failure from subcategory J960 or pneumonitis. Code J68.0. Associated respiratory signs and symptoms due to vaping, such as cough, shortness of breath, etc., are not to be coded separately when a definitive diagnosis has been established. However, it would be appropriate to code separately any gastrointestinal symptoms such as diarrhea and abdominal pain. If you want additional information on this, you can see 1C1.G.1.C.I for pneumonia confirmed as due to COVID-19. So, Chapter 11 for the diseases of the digestive system, codes K00 through K95. This is another chapter where this has been reserved for future guideline expansion and does not currently have any guidelines for us to cover. Now, for our last chapter for today's session, Chapter 12. This is for diseases of the skin and subcutaneous tissue for codes category L00 through L99. First up, we have pressure ulcer stage codes. Number 1, pressure ulcer stages. Codes in category L89, pressure ulcer, identify the stage and site of the pressure ulcer. ICD-10 classifies pressure ulcer stages based on severity, which is designated by stages 1 through 4, deep tissue pressure injury, unspecified stage, and unstageable. Assign as many codes from category L89 as needed to identify all pressure ulcers the patient has, if applicable. For additional information on this, you can see section 1B14 for pressure ulcer stage documentation by clinicians other than the patient's provider. Number 2, unstageable pressure ulcers. Assignment of the code for unstageable pressure ulcers, L89 dot, and the seventh character being 0. Remember, to be a full code, or sixth character, I apologize. To be a full code, you still need your fourth and fifth character, but for unstageable, your end character will be a 0. Should be assigned based on the clinical documentation. These codes are used for pressure ulcers whose stage cannot be clinically determined. For example, the ulcer is covered by eschar or has been treated with a skin or muscle graft. Remember, there is a difference between unstageable and unspecified. Unstageable means that they cannot determine it at this time, and unspecified means that there is no documentation regarding the stage of the pressure ulcer. Now, with unspecified, your sixth digit will be 9. So it will be L89 dot, fourth digit, fifth digit, and then your sixth digit is going to be the number 9. If during an encounter the stage of an unstageable pressure ulcer is revealed after debridement, assign only the code for the stage revealed following the debridement. Number 3, documented pressure ulcer stage. Assignment of the pressure ulcer stage should be guided by the clinical documentation of the stage or documentation of the terms found in the alphabetic index. For clinical terms describing the stage that are not found in the alphabetic index and there is no documentation of the stage, the provider should be queried. Number 4, patients admitted with pressure ulcers documented as healed. In this case, we do not assign a code for the documentation when it states that the pressure ulcer is completely healed at the time of admission. Again, no code is assigned if it is completely healed at the time of admission. Number 5, pressure ulcers documented as healing. Pressure ulcers described as healing should be assigned the appropriate pressure ulcer stage code based on the documentation in the medical record. If the documentation does not provide information about the stage of the healing pressure ulcer, assign the appropriate code for unspecified stage. If the documentation is unclear as to whether the patient has a current or new pressure ulcer, or if the patient is being treated for a healing pressure ulcer, make sure you query your provider. For ulcers that were present on admission but healed at the time of discharge, assign the code for the site and stage of the pressure ulcer at the time of admission. Number 6, patient is admitted with a pressure ulcer evolving into another stage during admission. If a patient is admitted to an inpatient hospital with a pressure ulcer at one stage and it progresses to a higher stage, 2 separate codes should be assigned. One for the stage of the ulcer on admission, and a second code for the same ulcer site and highest stage reported during the stay. Lastly, for this page, we have pressure-induced deep tissue damage. For pressure-induced deep tissue damage or deep tissue pressure injury, assign only the appropriate code for pressure-induced deep tissue damage to code L89 dot, fourth digit, fifth digit, and then your sixth digit will end in 6. So your sixth digit will always be a number 6 for your pressure-induced deep tissue damage. Next up, we have non-pressure chronic ulcers. So we have 3 guidelines for this. Number 1, patients admitted with non-pressure ulcers documented as healed. Again, no code is assigned if the non-pressure ulcer is documented as healed at the time of admission. Number 2, non-pressure ulcers documented as healing. It follows the same guideline as previously stated. If it is healing, the documentation for the appropriate non-pressure ulcer code is based on the documentation in the medical record. If the documentation does not provide information about the severity of the healing non-pressure ulcer, assign the appropriate code for unspecified severity. If the documentation is unclear as to whether the patient has a current or new non-pressure ulcer, or if the patient is being treated for a healing non-pressure ulcer, query your provider. For ulcers that were present on admission but healed at the time of discharge, assign the code for the site and severity of the non-pressure ulcer at the time of admission. And lastly, patient is admitted with non-pressure ulcer that progresses to another severity level during the admission. If a patient is admitted to an inpatient hospital with a non-pressure ulcer at one severity level and progresses to a higher severity level, again, as we previously stated, 2 separate codes should be assigned. One for the site and severity at admission and one for the site and severity at the highest level reported during the stay. If you want additional information on this, you'll see section 1B14 for pressure ulcer stage documentation by clinicians other than the patient's provider. That is going to finish us up for today's presentation. The only resource for today's presentation is the ICD-10 CM guidelines for the fiscal year 2026. If you have not already, please make sure that you follow the YouTube page, come over on Facebook and get on the Facebook page, and make sure that you hit the bell to be notified for all future sessions. Thank you all so much, and I hope you all have a great day. We'll see you next time.